Yeah, so what I'll do is run through the work that we've been doing. So I've been working with the Arts and Humanities Research Council, but under the umbrella organisation of UK Research and Innovation. Don't know if people have heard of those guys, familiar with them, but they're the main funders of research across the UK, apart from the National Institute for Health Research, which receives a huge health budget, but that essentially covers kind of biomedical and population health research. And this really all stemmed out of some work that I was doing with Arts and Humanities Research Council, AHRC, back in 2019, where they commissioned me to initially do some sector scoping of what were the research gaps in relation to arts and health. And in doing that, and for example, CHOA were very closely involved in that, in doing that, we were really keen to think about not just the field of arts and health, but that wider sector that interfaces with health across various different types of community assets. Hence the title of this presentation and the title of the programme, which I've then been working with them since 2019 to develop. So I'll just give you a little bit of background about the programme, what it looks like, and some of the sorts of research that we've been funding and the sorts of research questions that we are asking. So although this is led by the Arts and Humanities Research Council, it's supported by all the different research councils. And that is really significant because it's really, I guess, partly the fact that it's drawing funding from those other research councils and streams of funding centrally from UKRI, but also in terms of its transdisciplinarity. And that is quite unusual across research in the UK, but is becoming more popular. And we're seeing more evidence of it in UK research, which I think is really important in relation to things like community and health, because we know that these are very complex challenges that we're all facing, and so a kind of one size fits all is not going to work. And right from the inception, I brought in partners like the National Centre for Creative Health, so they're our official national partner. So we have shared posts with NCCH and shared streams of work like the Creative Health Review, but they're by no means our only partner. So we've been working closely with Victoria and CHOA, the LENS, the Lived Experience Network, the National Academy for Social Prescribing, and NHS Personalised Care. And in fact, the chair of our advisory board is James Sanderson, who's the director of personalised care in NHS. So what that's really helped us to do is think about joining up kind of evidence with policy, research, practice, and what some of those gaps are, what some of the key areas that we need to make progress are to bring about change. This programme is really about health systems change to make engagement with communities and community assets easier. And I can talk more about what I mean by that in a second. So it's a £27 million grant programme. And we've been running since funding research programmes since the beginning of last year. So we funded 12 projects initially as pilot projects, and most of those projects, I'll just give you some examples about those in a minute, but they're essentially hyper-local projects looking at quite specific types of activities and interventions. And we've just funded another 16 projects, and they're very much focused on kind of expanding collaboration and consortiums across academia, research and scholarship, community organisations, people with lived experience, and health and wider public health partners. And the pilot projects are sort of coming to an end now. The consortium building projects have just got started and they're running for 9 months. And we're just about to launch a new funding round to fund a series of 3-year long-term or longitudinal consortia where we have a £20 million investment. So we're going to fund about 10 3-year consortium research projects over the next 3 years. So just a little bit about what the programme aims are. And my job really has been working with all sorts of different partners across the research councils, thinking about what their strategic objectives are, how we might fit in with that, doing kind of evidence gaps, thinking about what the research priorities are, but looking at that not just from the perspectives of research, but in terms of thinking about communities and the communities ecosystem and how that can work more effectively around health, really bringing in all those different sorts of partners and stakeholder voices that we know we need to have in order to make change effective. And that's what my little diagram on the right is supposed to showcase, that idea of how we can bring about that sort of collaboration. So Quite specifically, we've had a focus on integrated care systems right from the start. And that's really because we think that integrated care and the changes that are going on across health and social care are the biggest areas that we think we've got a chance to make the biggest change in terms of systems change. And like I said, this programme is really about how we can bring about systems change, how we can develop testable, replicable models for collaboration across different types of community organisations and assets. And by that, we mean everything from arts, nature, culture, heritage, libraries, across other types of assets that we might not necessarily readily think of. So the faith sector, social welfare, legal advice. So really anything that could come under the banner of a community asset. So thinking about those models in relation to these changing structures that are occurring. And really what's at the heart of it is trying to understand these complexities that we know exist across these, we call them ecosystems because they're quite complex organisms in their own right. We know, of course, the diversity across the communities sector. We're all really, really different sized beasts, organisations from small, community voluntary-led organisations through to larger players like, AGK, Mind, big sector leaders, through to then all of the complexities that we know exist across health, social care and that wider kind of local authorities system. So what we're really interested in understanding those complexities, but particularly around barriers and enablers of integration across those two ecosystems. And so a lot of our job in terms of funding the research and our own national research programme is around converging data and learning from a whole range of different sites, both funded models, funded programmes that we are funding, research projects that we're funded, as well as other types of research and programmes and projects that are going on that are very interested in this area, to sort of get some shared learning on what some of those key barriers and enablers are, to get together a set of recommendations. So we have our own research project where we're working with the National Centre for Creative Health and those other sorts of partners to both support the funded research projects and work with other sorts of projects that we know are working in this area. And a large part of the work we're doing is around ecosystem mapping. So the sorts of mapping that Victoria just talked about is where we think is really, really important. Who is doing what where? What do partnerships look like? Who's involved in those partnerships? And then really understanding what works well in those partnerships and what some of the challenges are. And that includes all aspects of it, both the financial aspects. So what are some of the economic barriers, challenges that are faced at all those levels? What are some of the key working aspects of that partnership and how do organisations overcome that? And we've been collecting a whole range of data from all of those different people inputting in that. And then another key aspect, as you've already heard, really is that kind of knowledge exchange, working with national partners, doing stakeholder engagement, like the sort of work hopefully we'll be doing together today. So a lot of the work we've been doing is really about understanding these ecosystems. For example, here we can see our phase 1 projects. This is where we funded 12 projects across the UK. And these projects were really what I would call hyperlocal examples. So people, for example, we've got a project looking at wild swimming. We've got others that are looking at, for example, art at the start, looking at art therapies and arts-based interventions for new mothers, and how that can be better integrated into referral practices. So they're quite specific examples in areas where there either has been some really good practice and there's evidence that having some particular data would help inform that practice, or an area that has argued that there isn't much practice going on and they would really like to get that practice going because they've shown a real need in terms of those particular populations. So a big driver for this has been around the issue of inequalities and how applicants have had to demonstrate what their understanding of inequalities and how they're going to address that through the research and through the partnerships. So a lot of what we've been doing is mapping, helping them by mapping both what kinds of organisations they are, but what kind of other assets and organisations, and particularly on the health side, exist in their area. And many of them are already linked up, but ensuring that they are linked in if they're not correctly linked in, and how to broker those sorts of conversations. And here you can see the diversity of projects funded under phase 2. That just, I mean, just some of the titles give you an idea of the sorts of projects that are being funded through this programme. What I can't do is show you the individual ecosystems for each project, because what has been amazing is how extensive they are. And that will be no surprise to many of you guys, because you're already involved in very, very extensive networks yourselves. But even when we've got projects that are really targeted, say, on a specific population or a specific geographic area, what has been amazing is to look at the very local and hyper-local ecosystems that often are down to neighbourhoods that those collaborations are forged. And for us, what's been really important is understanding the dynamics of those sorts of partnerships, particularly around sustainability. Most of them are partnerships that have been working for a long time in some capacity, but have used this research funding to grow that collaboration to undertake a specific piece of research. So some of these projects I'm sure some of you will already know about. And again, like I say, a lot of our focus has been really doing data gathering, both from those projects and other projects, and overlaying on that data and knowledge that we can extract, for example, in relation to local public health data, local population health data, local indices of multiple deprivation data, ONS data. So a lot of our focus has been how we can bring together different types of data, evidence and learning to understand all the complexities of that ecosystem. And for us, a lot of that focus is around how we can make better decision making for all those stakeholders, whether that's decision making when it comes to commissioning, or whether it's decision making when it comes to referrals, or when it comes to partnerships. So a lot of our ecosystem maps, this is quite a simple one. I can't put some of them on a slide because they're just too complicated, but it's just to map who those people are, where they're based, and how those networks are interacting with each other. And then what we do is go in and speak to all of those different partners, stakeholders, the people engaged in those programs, the people delivering those programs, the researchers, the providers, to understand the dynamics of that ecosystem, and again, understanding those barriers and enablers. So we have quite a complex theory of change, and a lot of it involves a lot of mapping. So I'm not going to go through any of this in detail, but part of the complexity that we've added in is by bringing in a whole range of other projects that are quite similar in a way to this programme. I'm sure many of you either will be part of or know about the Thriving Communities programme. Also had very similar ambitions, particularly around inequalities. There's a series of other research programmes going on. You might know about the Green Social Prescribing, Test and Learn sites. The National Centre for Creative Health has got creative health hubs where they've been doing research and mapping around 4 integrated care systems. The National Institute for Health Research have just funded a series of 10 health determinants research collaborations. They're quite a lot larger than our funding available. They're £10 million each, and they've been posted in places that have, that we know have got issues around deprivation. So, for example, Blackpool. But what's interesting about those is those are basically planting researchers and research capacity within local authorities. So definitely an overlap with our programme and with many of these other programmes, but what we're interested in is, again, how these slightly different funding investments are gathering data, evidence, and from our perspective, how can we bring all of that data, evidence and learning together to advocate for better systems working for community organisations and lovely other partners like CHWA and people like the What Works Centre for Wellbeing. So, I mean, I don't want to spend hours today talking about the outcomes because, as you can imagine, we've got a lot already just from the projects that we've been running so far. So I just thought I'd mention a few and then summarise a few key findings that I hoped might be a vehicle for us to basically having a little chat about what your perspectives on that, what your experiences of some of this work are, particularly around inequalities. So I've just picked out a few here. A key aspect of the work we've been so far is identifying key themes, as I say, around barriers and enablers around partnership working. And the key things that came out, particularly for community organisations, which is no surprise to all of you guys, is what this argument that we can have a wider reach and depth of social impact than, for example, health and social care services. And in times of massive change and flux and lack of funding, that is really, really important. So these are really important arguments, I think, for us to make in terms of arguing for better investment in this area. Also, just thinking about some of the barriers that there's been no real investment in tackling inequalities. I think that's why this programme has received quite a big investment from UK Research. The initial investment they promised us was going to be about 2 to 5 million. And then UKRI looked at the proposal that I drafted along with lots of input from people like Victoria and others, and decided to up it to 20 million. And we may get more investment as we go forward with the programme for the other research councils. But there's been a real issue in knowing how to tackle inequalities. And that has come from not just health and social care professionals, despite things like Core 20+5, which some of you may be familiar with, that's the NHS's approach to tackling inequalities, but also from community organisations who, for example, may have really, really great local or hyper-local understandings of from their own communities that they work in, but won't, for example, have access to local population health data, where they might be able to have a broader understanding of other issues around inequalities facing different members of the community and their population. So we know that kind of access to different types of knowledge, the sorts of language barriers that we all know exist across these two very diverse ecosystems, can be a big barrier. But a big area that has come out on both sides, again, not just from community organisations, but from example, health, social care, health professionals, has been the fact that community organisations have, as we know, the amazing experience of being aware of it and being able to listen to the realities of lived and felt experiences, and have really effective ways of gathering that intel and helping to think through what that might mean in terms of systems change. So loads of other stuff which I won't focus on today, but that has sort of led to, I guess, a few key findings for us as we've in terms of where we're at the minute. And I don't think any of this, I hope, will be a surprise to you all. And I think much of the work that I know that you guys are doing or involved in, or your organisations that you support, are recognise this, that community-based solutions offer targeted approaches to reaching those most in need, living in the poorest areas. And that is often in contrast to standardised health services, where we know, obviously, due to demand, due to issues with staffing, due to issues associated with COVID, funding, of course, that reaching the hardest to reach people is really difficult to do in a targeted way. It's really difficult to do in terms of prevention and actually in terms of intervention. We know that asset mapping is really important to identify strengths and gaps in the community, and that we need to do this in order to ensure that offers are relevant to the needs of the local community. But we know that that's really challenging. If you're a really small organisation, just understanding what else is in your area is a really big time-consuming feature of the work that you just don't have time to do, or resource, or maybe skills to do. And we know that we need to involve local people in that whole process. In terms of asset mapping, obviously local people are some of the best people to help with that. So we're seeing more and more examples of community researchers helping with that process of understanding what the needs are in the local community, and also what kind of assets are available in the community, but also what's missing, because we know that that's a key driver in terms of inequalities. And a key objective for us really is about trying to make it easier for decision makers. And by decision makers, we mean everybody involved at all levels, whether it's a referrer, a funder, a commissioner, and those different professionals looking to deliver services and provide access to services or activities or programmes. Particularly in terms of addressing inequalities, and again, identifying who needs it most, so ensuring that it's targeted. And we know that's been an issue, say, for things like social prescribing. It hasn't always necessarily been targeted at the people that might benefit most. So, for example, how can we identify people with complex needs, people with multiple comorbidities in society that are facing particularly complex problems? We also know that that there's many issues with current models of funding and commissioning. That, of course, is not a surprise to any of you, but we've seen that the best types of approaches to funding and commissioning are locally based, and that co-location of services and that collaboration across organisations and programmes is much more effective and offers the most cost-effective solution to tackling inequalities.